Hello. Thank you, Professor Chairman, and all the panelists and my dear friend here. Thank you so much for staying here, and I think that it's the best for last. Yeah, I hope my presentation will have some information for you. I don't have any conflict of interest. So let's begin with my case. It's a 69 years old female patient who are presented with our center with this dyspnea, peripheral edema, and palpitation. So her medical history is significant for the dyslipidemia and recent non-STEMI for that's 2 weeks ago. And she has undergone the PCI with a stent implantation to the LED and were discharged on the optimal medical therapy with documented adherence. Upon the admission, her condition deteriorated very rapidly, and she has a sign of shock with the hypotension, prolonged capillary refill, and oxygen desaturation. And clinically, we also noted the soft to moderate the hollow systolic murmur at the apex, and the patient were admitted to the intensive care unit. And initial investigation revealed that anterior necrosis on the ECG and chest X-ray also, you can see a sign of the pulmonary edema. NT-proBNP were extremely elevated, and a check of the coronary stent was confirmed with the LD stent was patent. So based on this finding, we classify the patient have the SCAI C, type C, the cardiogenic shock, and we are immediately management, including the oxygen supporting for the patient. We have the noradrenaline to maintain the heart rate, the BP above the 60, and we carefully titration of the IV diuretic when the BP is stabilized. And we also consideration about the bedside MCH for the patient, and we order under TE to assess the mechanical complication. Especially we have the heart team consideration about the mitral clip versus the surgical option for the patient. So I will go through all the echo finding. So this one, the left atrium is severe dilated, and you can see that LAV index is 85. So this is over upper normal limit. And the mitral valve leaflet are mildly thickening. The left ventricle also that's dilated. On this slide is a apical view. You can see that the mitral regurgitation extended to the roof of the atrium, and the mechanism of the MI here is mixed from the functional and degenerative on that patient. And on LVOT view, they reveal that severe eccentric mitral regurgitation, and we think that this is near the A1 and P1 scallop junction, and possible the cordial ruptures. And this one, this is the source axis view. I don't know that any echo guy is still here, but we can see observe the anterior mitral leaflet prolapse. And finally, that we check the vena contracta is 10, EROAS is 0.6, and we also check the ratio between the mitral annual diameters and anterior mitral leaflet length. And since this ratio is more than 1.5, so indicating that the patient have also the functional component contributing to the MR. We check what about the patient is suitable for the mitral clip or not, and we check did the flow gap is 9 and the flow wide 11. So due to the average trial, so suggest that the patient is quite suitable for the mitral clip therapy. Leaflet length, anterior and posterior leaflet also check also, and on 3D, and you can see that confirms that the beginning of the regurgitation is coming from the A1P1 scallop interface. And we also check the mitral valve audio area. This is 4.8 centimeter square. So this is one that's suitable for the mitral clip without inducing the mitral stenosis. We convinced, this is the heart team meeting, and giving her the critical state, and her Euro score was the 70, nearly the 18%, placing her the very high surgical risk. And with no thrombus in the left atrial appendix, and the consensus was proceed with the percutaneous mitral valve repair indicated. And as we know that the anatomy is very suitable, very critical, patient have the complex, and you can see that it's a yellow line, and but not contraindication anatomy for the TIA. So now we proceed with very carefully planning about the TE. initially that we want to directly grab the leaflet with the A1P1 scallop, but we have some challenges. It's a wide prolapse and short posterior leaflet, and we have some risk of incomplete leaflet capture for the patient. So we, at the beginning, that we just want to go to the A1P1 area, and we successfully grabbing the posterior leaflet, but we cannot grab the anterior leaflet being captured. We take time, it's about the 30 minutes, and finally that we can capture the anterior leaflet. But when we close the clips, the anterior leaflet is slipping out. So this one, yeah, I just want to explain you more about this modified strategy to buttoning a loose shirt. Sometimes that when the opening is too wide, you cannot start with the first buttoning of the A1P1 as you wanted, because this one doesn't meet. So now we have to start at the very central with the A1P1 to narrow the gap first. Once the valve geometry was stabilized, and now the gap is smaller, so now you can grab with the A1P1 like fastening the next button, and now so you easily to grab the A2P2 first, and finally that you can grab the A1P1. So we follow this step. So firstly, we first clip deploy the A2P2 as the anchor, and we use the anterior leaflet mobility, and we clip. We still have some residual significant MR remaining here, and you can see. But after deploy the first clip, and you can see that we still have some residual prolapsing segment. But however, the leaflet mobility and the fail gap between significantly reduced. So now we have room to the second clip. So the second clip will deploy with the A1P1 with carefully attention to maintain the appropriate distance from the first clip. And this is the results after we deploy the second clip. So the mitral rotation significantly reduced with the only mild residual jet. We can see on the color Doppler. And this one, the clip was deployment, and we see that the lip mobility was significantly reduced, and after second clip, was deployment. And so in conclusion, that after the mitral rotation patient was significantly reduced, previously you can see that we have very big regurgitation jet, but after now we can divide it in two small residual jets, which we decrease significantly. So patient follow up and discharge in the stable condition on the GDMT, and we maintain regular cardio follow up with subtained clinical stability as good as adherence. So just some theory. What's for the secondary MI in shock? There is an indicator on contributors. So the case is critical debate. In secondary MI is shock, is indicator of bad LV function or a contributor for the shock state. And we know that with the severe MI diverse this is the cycle or low input, and pulmonary congestion. In this patient, if you cannot cut this cycle, you cannot stop the cardiac shock for them. So we look back about the guideline, the recent guideline 2025 from the ESC and 2021 in ESC guideline for the heart failure. We don't have any specific recommendation for the cardiogenic shock patient with severe secondary MR. So this one, we have to individualize patient. Based on each patient, we have the each decision from the heart team-based discussion. But here we have the consensus paper. If the patient have the shock and we cannot control, the patient cannot control the shock, so we have to intervene like the MTR or the surgical for the patient. We have any data for the MTR in cardiac shock? Yes, we have. We have some the small data because we cannot have the RCT for in very critical patient. So this older data show that mitral clip is associated with a significant better survival compared to the conservative management. And as we can see that in the graph, after 1 year survival probability is higher in the intervention arm when we compare the conventional treatment for the patient. And also we can reduce the risk of morbidity and heart failure rehospitalization after the 19 days, that we can appreciate on the graph. So that's one bring me to the conclusion. The mitral transcatheter edge-to-edge repair with mitral clip is a viable alternative to surgery in selected high-risk patients with acute ischemic mitral regurgitation and cardiogenic shock. And patient selection is very important and critical. We have to identify what about the appropriate candidate for the MTR in context of the QMI, considering of anatomy, feasibility, and clinical contraindication. And echo finding also very important, especially for the DEE, play in pivotal roles in diagnosing MR mechanism and guiding procedure planning and execution. And the multidisciplinary, the heart team, essential for the optimal decision making and outcome in the critical ill patient. So thank you for your attention.
Yeah, thank you very much for that great lecture. It's a very exciting new field. Even though there's no guideline statement, we have clearly seen it being used very successfully in many patients. We've even seen it used successfully in non-ischemic patients who have endocarditis, for example, who are too sick to undergo surgery. We've actually put the mitral clip in to get them better and then use it as a bridge to surgery. Obviously, that option is very expensive, but you know, it's doable. So this is a new frontier, right? In China, some of my friends are saying that they do 20% of their TAVRs at their centers are in patients in cardiogenic shock, which is remarkable. So there's definitely a role for structural work in cardiogenic shock because those patients really usually have no other options. The only issue is expertise and cost, and you showed this very nicely. How many cases in Vietnam have they done in mitral MTR in cardiogenic shock? Do you know on a national level? Has anybody talked about it?
Yeah, this is a long story. We started the mitral clip 11 years ago in my hospitals. And so far we have the 40 cases in the whole Vietnam. So it's not too much cases, and we restart the program this year. So until this year, until the 3 months when we restart the program, we have the 3 patients already. This is the problem that the price is quite very high. The patient don't have any support from the insurance, and not too much patient can afford it. Yeah. So now we have a lot of competitors from China.
Yeah,
Dragonfly.
Dragonfly.
And my clip from India also. So we're coming into the next year, and I think that if we have a lot of competitors, we down the price, and a lot of patients can be afforded.